Right. Thank you all for joining us this afternoon. We welcome you to our Ask the Expert live Q&A webinar. I know you all are busy, so I definitely want to express my gratitude for you taking time out of your day for this session. I'd also like to thank PECAA for giving us the time to conduct this session and discuss your most burning questions. To those who were able to submit their questions in advance, again, we appreciate you. If you did not have a chance to submit your question, please feel free to go ahead and type it into the question panel now. As we go along today, all participants will be muted, but if you have additional questions on any topic discussed, please feel free to also type those into the question panel. We will get to them at the end. And please also note that the session will be recorded and we'll send out the slide deck after the webinar, so you will have a copy of it if you'd like it. My name is Jacobson, and I am the operations manager for RevCycle Partners, or RCP, as we affectionately refer to ourselves. I have been with RCP since early 2019. Prior to that, I spent 12 years with a 10-location optometric practice, where I started as tech and worked my way up to chief operating officer. With me today, I have a few team members. Casey, would you like to go ahead and introduce yourself first?
Absolutely. Thanks, Melissa. So my name is Casey Squeakerow, and I am the Staff Development Manager here at RevCycle Partners. And in my position, I provide ongoing development and support training for both our new and our existing billing specialists. I've been doing optometric billing since about 2010, and I started working in an eye clinic local to me, and I've been with RevCycle Partners since 2014, and in my current position since 2018.
Good. And Danielle, would you like to introduce yourself as well?
Yeah, my name is Danielle Kiger, and I'm a Billing Services Group Manager with RevCycle Partners. I've been with RCP since 2017, and I've been working in various aspects of the optometric field since 2008.
And Sarah.
Hi, my name is Sarah Gray, and I'm a billing specialist at RevCycle Partners. I've been working in the optometry field for 14 years, mainly in a solo practice setting for 7 of those, being the jack of all trades in the office before starting with RCP in 2019. In my position, I not only work directly with offices for their billing, but I also focus on aging, which includes training our new and existing billers on best practices for completing and maintaining their own aging for their offices.
Excellent. Thank you. So we had a series of questions come in, and we're just going to tackle them one by one. We'll start with Casey and a question on Medicare as a secondary payer to get us going.
Sure. So looking at the question here, I'll just kind of read it for us, and then I'll go through what the answer would be. So this question came in. It says, how do you submit a secondary claim to Medicare if a patient has a commercial plan through a spouse or is a working age beneficiary? So this question, I think, can be pretty challenging for most billers. So Medicare contractors can have different requirements for submitting Medicare secondary claims. These claims are also known as MSP claims. So you would want to start by looking at your Medicare contractor's webpage for their specific billing requirements. But the first thing you'd want to do is start by determining if your contractor allows for one or more of the following ways to submit those MSP claims. So you would either submit the claims electronically through the contractor's portal. If you have portal access, you can submit them electronically using your office's clearinghouse. And then also there may be the option to submit these claims paper. So paper claims are pretty rare because when you're a Medicare contractor, you do have requirements to submit claims electronically unless you have a allowance or a waiver on file that says you have such a low number of Medicare claims that they will allow you to submit those claims on paper. So you'll also need to ensure on the claim that you list the primary insurance information along with the MSP or the secondary insurance information. You need to make sure you have the primary subscriber's info on the claim if it's different from yourself. In order to bill MSP claims electronically, even on paper, there's several pieces of information that are necessary to ensure your claims process and adjudicate correctly. So they do require, I think I mentioned that they have all of the primary payers information on there. Medicare must be listed on the claim, indicating that they are the secondary payer. Important piece of information is the insurance type code. So this is specific to the question where it says, this MSP claim would be going over as a spouse or a working age beneficiary. And in this case, you would have to indicate that on your claim. So the coordination of benefit, it also needs to show the paid amount from the primary, all of the adjustment amounts, and then the service line, like data as far as like what was a write-off, what was patient responsibility. If you send in a claim that's paper, you would also want to mail in a copy of the primary payer's EOB. If you're filing the claim electronically, there's going to be an area either on the portal or on the clearinghouse claim submission where you can indicate the insurance type code. So specifically for this type of claim, it would be 12. So 12 says that you have Medicare as a secondary payer because you are a working age beneficiary. So that code and where it goes is usually the most forgotten piece of information, but it's going to be specific to how you're submitting it and what your Medicare contractor requires. So when you are on your Medicare contractors page, search up MSP claims instead of Medicare secondary. MSP will give you a better listing of results.
Okay, so next question we received was if a patient hasn't met their Part B deductible and they are a QMB member, but the office is out of network with Medicaid, do you collect the deductible from the patient? So this question does come up often, and it's really important to know if a patient is a QMB patient, which is a qualified Medicare beneficiary or a patient that has been enrolled in both Medicare and Medicaid that meets certain qualifications, and the office is not in network with Medicaid or that particular state's Medicaid. So possibly you're on a border state and they have an out-of-state Medicaid, or they're visiting your state and have an out-of-state Medicaid. You are prohibited by federal law to collect copays, coinsurances, or deductibles from the patient. So even if an ABN is signed, the patient cannot be billed up front for any amounts. You must wait for Medicare and then Medicaid to process. And then if they don't, if you aren't in network, of course, Medicaid's not going to process, right? So you have to wait for Medicare to process. And even then, it's not guaranteed what can be shifted to the patient, even with your signed ABN. So you have to look at your state law and use caution if you're attempting to shift any responsibility to the patient. If you bill a QMB patient any amounts, if you do this improperly, and again, it's not your coinsurances, your copays, your deductibles, right? It can lead to issues with Medicare. So it's important that you check with your state Medicaid billing and their requirements before billing any non-covered Medicaid services, especially if the patient's a QMB plus, which means they have a full Medicaid benefit. So when you do have these patients come in that are Medicare and have Medicaid and are QMB or QMB plus, and there's a few others as well. There's SLMB and different ones. You have to know in advance if they are that or not, so you can determine what or if anything can be collected from them at the time of service. You can check their eligibility through the Medicare portal or through calling Medicare's eligibility line. So there are ways, if you don't have that Medicare portal, to check to see if a patient's QMB prior to them coming in.
And it looks like we had a question come in with the differences for traditional Medicare and Railroad Medicare and how you can tell those differences with the newer ID cards. I'll answer that first before getting into the how you get paid with Railroad Medicare. The big confusion with the Medicare types end up coming into play with their card. You're able to tell the difference with the way the card is listed on the very bottom of the card. The Railroad Medicare will list that it says Railroad Retirement Board, as well as a specific logo in the upper left-hand corner. This logo differs on both a traditional Medicare and Railroad Medicare card. The identification numbers are both going to look a little different now because they did move away from that the patient's SSN-based IDs. So make sure you're checking those. They do have the same amount of letters and numbers in both of them. So the biggest difference to look for would be those logos. And you can save a lot of time and possible submission errors by checking those cards and getting those cards up front from the patient. Now, when it comes to getting paid by Railroad Medicare, you first have to make sure that you're a provider participating with your local Part B Medicare and that you have that PTN information. You would then have to request a separate Railroad Medicare PTN. To obtain that, it's a little bit different than the process you went through for the credentialing for Medicare. You're going to want to submit an initial claim to Railroad Medicare. Usually there are chances that they will allow that first claim to come in as paper if you have the I'm sorry that I'm getting mixed up on things right now. If you have that little bit of that liability or the form that Casey had talked about to allow that to come through. But once Railroad Medicare receives that CMS 1500 form, they'll obtain information directly from your Part B Medicare provider to obtain that specific PTN for Railroad. You'll then receive a letter from Railroad with the specific PTN that'll be just for Railroad versus the traditional Medicare. Make sure you keep that letter on file because it'll have your information for your effective dates and other things like that. After that initial claim is received and submitted to Railroad, they will need to be submitted electronically. To submit that electronically, you may need to work with your clearinghouse or directly through the Palmetto GBA Railroad Medicare portal. For the clearinghouses, there may be a separate enrollment process to follow for the EDI. And once these claims start to be received and processed, you can then start to receive your electronic payments and remits. You may once again have to go through special setup through the clearinghouse or directly through the Palmetto website. And just as a reminder, anytime that there are any changes to your local Part B enrollment, such as like a revalidation, suspension, things of that nature, these activities will have to happen with your Railroad as well.
Perfect. So a similar question, along the topic of traditional Medicare. This one is actually referring to the differences between traditional Medicare and Medicare replacement or Medicare Advantage plans. So the question was, I am participating with both Medicare and United Healthcare. When a patient comes in with United Healthcare Medicare Advantage, who do I file the claim to? And the simple answer to the question is United Healthcare, right? What's important to understand is that Medicare has 4 parts, right? So Part A covers hospital, some skilled nursing and hospice services. Part B covers outpatient services. This is the part that you're using most of the time when a patient comes in to see you using traditional Medicare. As you probably know, Part B covers 80% of the Medicare total allowable after the patient's deductible has been met. And if the patient has a supplement or a Medigap plan, it can pick up the remaining 20%. And also some supplement plans will pay a portion of the yearly deductible. The third part, the third type, right, is Part C, and that's an alternative to Part B. So if the patient enrolls in Part C, they're actually electing a managed Medicare or Medicare Advantage plan. Most of us will sometimes refer to this as a Medicare replacement plan. So these plans have at least the same benefits as Part A and Part B, but they're often a little bit better. They may include routine vision, for example. And then the fourth part is Part D, which is prescription benefits. And so if a patient is enrolled in Part C, you'll always bill the commercial payer as primary. You should not bill Medicare at all, not even as secondary, right? That's going to be only Part C. The only time you would ever bill Medicare as secondary is in those scenarios that Casey mentioned previously. So the commercial payer has basically replaced Medicare, right? So in this instance, United Healthcare Medicare Advantage is a Part C plan. And knowing which plan your patient has is incredibly important. So be sure to get copies of those cards and know that just because the patient hands you a traditional Medicare card does not necessarily mean that they have Part B coverage. They probably enrolled in Medicare first and then later chose to get Part C, replacing Medicare, but didn't actually destroy that Medicare card. So the payer portals can be invaluable in helping you determine what benefits the member is actually enrolled in and who the primary payer is. Oh, you're muted still, Sarah.
Sorry about that. Moving on to our next question, we did have a lot come in regarding the co-managing cataract surgery. And the first question was that I'm struggling to get paid on my post-op co-management claims for cataract surgery. I've done the post-op care for both eyes. Each time I try to bill Medicare, it comes back denied. What's the proper way to set up these claims? Well, that second question that came in regarding what order the modifiers for 55, right, and 79 should be in also kind of plays into this. The first thing you want to make sure is that you have a transfer of care or written transfer agreement from the surgeon's office where the surgery is taking place. This should include pertinent information for the patient and procedure, the date of surgery, surgeon's name, CPT code and diagnosis code billed, as well as the eye that was being operated on would be the most important needed. The optometrist would assume care of the patient the following day. This form would also include a transfer date. One of the biggest denials that come back in the post-op care claims is usually the code that comes back with B20, which states procedure service was partially or fully furnished by another provider. This is caused by the surgeon's office not billing their claim prior to your office submitting their surgery claim. And it could also be or include the appropriate modifiers not being billed on their end. And in some cases, no modifier at all. They would need to include a 54 modifier, which is for surgical care only. The optometrist should bill with the 55 modifier indicating postoperative management only. In these cases, you'd want to reach out to the surgeon's office to verify how they billed. If it was billed incorrectly on their end, you may have to wait a few weeks after they resubmit or correct their claim before resubmitting your office claim. And Melissa, if you could go over to the next slide, I'm kind of going to go into a little bit more on the claim form and some other things that could possibly cause some issues when submitting those post-op claims. You're going to want to ensure that your diagnosis code matches what the surgeon's diagnosis code is listed as well as the CPT coding. If it was a 66984 for a regular or 66982 for complex surgery. The date of service is the actual date of the surgery, which would be located in box 24A. The surgeon's name and NPI, which would be in box 17 and 17B, possibly weren't listed as the referring provider. Box 33, which would be in the lower right corner of your claim, needs to have the optometrist information and the practice information, not the surgeon's. Box 24G for your days and units. This is one that sometimes causes some issues. Medicare Advantage plans, along with commercial insurances, normally accept 1 unit and you bill for the total amount of the co-management period. Traditional Medicare in some cases will only accept 90 units. In this situation, you would divide the number of days you co-manage the patient by your total fee and dollar amount to come out to your per day amount. An example of this, say, would be is if one unit equaled $300 versus 90 units, which would then be broken down to $3.33. This sometimes may vary per the Medicare carrier. When it comes to your modifiers, you'll want to have it go listed first your CPT coding, so the 66984 or 66982. Then it'll be your right or left, depending upon the eye that had surgery, and then the 55 for co-management. The 79 modifier comes into play when there's a second eye done in the global period. In that case, you would have your CPT coding, then right or left, the 55 for co-management, and then adding the 79, which is the unrelated procedure during the post-op care. Box 19 is something else you want to look at because you must include information along the lines of 90-day post-op, the date you assumed care in the office, and then the end date of the global period. You can actually find that information by using a surgery calculator on the Palmetto website. And then moving on to that, kind of speaking into the global period, I'm going to pass it along to Danielle, who's going to go into that a little more in depth.
So like Sarah had mentioned, we received quite a few questions about those post-op cataract claims, and one that is specific to global periods and the transfer of care dates is when calculating the dates on a cataract co-management claim, does the 90-day global period start from the day you assume care or from the date of actual surgery? So the 90-day global period starts on the surgery date for your post-op cataract care, not the date that you assume. So if you assume next day or a week later, you're still going to use that original surgery date as your global period date. When setting up the claim, you'll want to make sure that your assumed date is the date you're assuming care. However, that relinquished date will be the 90 days from the date of surgery, not of course, the assumed date. So it's recommended, like Sarah had mentioned, to use the global surgery calculator from Palmetto. They're a really good one to help calculate these days. Simply, you'll put the date of surgery in the calculator and how long the global period is. So they do let you choose 90 days, which would be what we would use for a post-op cataract, when they also have a 10-day option for other procedures, and the calculator will give you the relinquished date. It is important to get the exact date of surgery from the surgeon, as well as the day they are relinquishing care back to your office to have an accurate claim, as Sarah had mentioned. That should all be available on that transfer of care letter that is provided to your office.
Thanks, Sarah and Danielle. Those were all really good questions about post-op. So I think this one is another great question too. So the question came in as billing epilation. So CPT 67820. If billing on both eyes the same day, do we bill two lines, each with modifier 51, or should it be on one line with modifier 50? So when billing a procedure such as epilation, when it's performed bilateral, which means both on the right eye and left eye, and it's on the same day, there may be different billing requirements depending on the payer. So when billing this to Medicare, this code would be billed on one line, and you would bill it with a 50 modifier. So 50 modifier will indicate a quantity of one, but the price will actually reflect the quantity of two. So it needs to be double the price. This information is actually obtained through Medicare's MULE tool, which is medically unlikely edits. It's MUES, it's MUES. It tells you the maximum number of units that can be reported on a procedure. And when I look that up on Medicare or CMS's tool, it shows that 67820 has a mu value of 1. So one tip that I want to just reiterate is that when there's a value of 1 and you're billing it with the 50 modifier, always make sure that the units listed on that line are not 2. It's units need to be 1 and the price is doubled. So, and when you bill that way, you'll actually get reimbursed 150%. So it'll be 100% of the first unit and then half or 50% of that, or first eye, and then 50% of the second eye. So for commercial payers, though, they may have a different billing requirement from Medicare. So in the case that a commercial payer does allow for the procedure to be billed on two lines separately, you would not put the 51 modifier on the first line. So you would bill one line with the 67820. You would have to indicate right or left, along with well, on the first line, just the right or left. On the second line, you would have the 67820, a 51 modifier, along with the right or left anatomical modifier. So one other thing too is with Medicare, they do not want you to report the 51 modifier on multiple procedures. In most cases, Medicare is going to require a multiple procedure to be on one line with the 50 modifier. But even if you would report it on 2 separate ones, you would still not indicate the 51 modifier on the second, or if there's additional lines after the second, you wouldn't report that either. And then lastly, I just want to mention that if the procedure is being performed only on one eye, then the units would be set to 1, and you would just indicate right or left along with billing the 67820.
Very good. So this question is specific to billing just in Minnesota, and it's asking about billing replacement glasses under Blue Cross Blue Shield and Health Partners. So the question is, the manual outlines change requirements. The patient does meet these requirements, but claims are still denying. Should we bill with modifier KX? So modifier KX is actually not the most appropriate modifier in this case. KX is meant to be used to indicate on a DME claim that the item is deemed medically necessary. It's typically used in eye care to indicate a particular lens option is deemed medically necessary and should be covered when it would otherwise be denied. It's not usually used for an entire pair of glasses. For example, it might be used on a claim for post-op glasses for a patient who has monocular vision to ask that polycarb be covered because the doctor has deemed it medically necessary. So instead of using KX in this situation, modifier RA is typically what these payers are looking for. So the RA modifier is used by these payers and many others actually to indicate that this is a replacement pair under the patient's replacement benefit. As long as the guidelines have been met per the manual, you should be able to bill the claim with RA on each line and get paid under the replacement benefit. Just be sure to notate in your chart, of course, that, what the reasons are for the replacement pair so that if the claim is denied, you can submit your records and show that this was a replacement pair under the replacement benefit. You're still muted, Casey.
Sorry. Okay, so shift into another modifier question here. It looks like, okay, so using modifier GY on refractions, can you address the GY modifier, particularly for refractions being submitted to Medicare and Medicare Advantage plans? So first, I just want to make sure we all understand what the GY modifier means or tells us. So when GY is appended to a claim or to a line item, it's saying that that item or service is statutory excluded. So it doesn't meet the definition of any Medicare benefit. So refraction would be one of those. So that in the correct use of the modifier would be used so that you could, most likely, so that you can obtain a denial for a non-covered service. And it would determine, the GY would help it determine whether or not it goes to patient responsibility. So As far as submitting claims to Medicare directly, the GY, it's not needed if you're just looking for Medicare to process the refraction as patient responsibility. It's going to automatically process it as patient responsibility on the refraction without the GY modifier. However, if the secondary after Medicare or the supplement, if it is stating, and that payer stating that they need the GY modifier to be present on the claim in order for it to cross over correctly, and in order for them, the secondary payer, to consider payment, then billing the GY modifier on the refraction with Medicare, it won't cause any problems, and it could possibly help that supplement or that secondary claim process and pay correctly. And it'll be forwarded to the supplement with the GY modifier on there. However, when it comes to a Medicare Advantage plan, then you may find that a G modifier, not necessarily the GY modifier. So a G modifier, there's GA, GZ, GX, that it is needed in order for that payer to process something like a refraction as patient responsibility. So I found that when this billing information, when billing an Advantage plan, their requirements specific to the G modifiers are normally either on the in the provider manual or on a medical policy within that payer's payer portal or website. So each commercial plan or Medicare Advantage plan, they may have their own set of policies on billing something that's considered non-covered. And if it's not even a G modifier that they require, it might be something like a non-covered form that has to be filled out, or an ABN might need to be on file. And just remember that when you obtain something for non-coverage, for a non-covered service, an ABN or a form, it has to be obtained prior to billing the service. Your patient has to be well aware that that service is non-covered. That form is going to indicate to your patient that they, may be billed, what the date of service is, how much they'll be possibly billed. All of that has to be obtained at each service. You can't obtain an ABN at the beginning of the year and then use that for non-covered services throughout the year. These forms or an ABN has to be obtained at each visit prior to billing.
And then moving on to our next question, came in, should a refractive diagnosis be used in the primary position, as well as is Z01.00 or Z01.01 more appropriate in terms of billing routine exams to medical payers? Seeing as though we're not medical coders and it could vary by the insurance company, which would be appropriate to use, determining what should be used would be at the doctor's discretion for using a refractive diagnosis code or Z code for the routine exam. While both codes can be considered screening codes, Z01.00 would most often be used for patients with no refractive error and no medical diagnosis. Z01.01 is to be used if a patient does have some kind of refractive error like myopia or astigmatism. The use of these diagnosis codes do rely on whether or not the payer requires them or recognizes them. Some payers may consider this a DX, a screening, like the ones done at your primary care provider or child school. And unless the payer requires the use of Z codes, most providers agree that it's best to code with the highest specificity of the codes. This would mean using refractive or medical diagnosis instead of Z codes.
All right, here's another one on modifiers. These two questions actually have to do with modifier 26 and TC. So for those of you who may not be familiar with these modifiers, a little bit of information first. Modifier 26 represents the professional component of a service, the interpretation and report of a test that was performed, while TC represents the technical component of the service, performing the actual test itself without the interpretation and report. When reporting a service with one of these modifiers, the payer is actually going to split the fee for the entire test based on their fee schedule and the modifier reported. Now, it's important to note that these modifiers can only be used on select services. They're specifically the services that have a 1 in the PCTC field of the Medicare physician fee schedule. So if you go out to the Medicare physician fee schedule and look at the PCTC column, you're going to look for the procedures that have a 1 in that column. Some examples that can be used with 26 and TC include 92083, 92134, and 92250. So your visual fields, your OCTs, your fundus photos. Now, the first question that we have is, if a patient comes in for visual field, but only has the test done that day, and the doctor is going to review the results later, how should I bill this? This is actually a great example for the use of modifier 26 and TC. The procedure code 92083, as I mentioned, does qualify for the use of these modifiers per the physician fee schedule. So if only the test itself is being done on the first day, the claim should include 92083 with modifier TC for the technical component, that test. Then, when the provider reviews the test on a later date, doing the interpretation and report at that time, a second claim should be filed for 92083, but this time modifier 26 should be appended. Now, the second question is, can TC and 26 be used for 2 different tax ID offices? One does the testing only, and the other does the INR only. The answer again is yes. This is another good example for 26 and TC. If, for example, you have an OCT at your office, but a colleague does not, they could refer their patients to you for the technical component only, and then have the patient return to them for the professional component later. So you would bill the 92134, for example, with modifier TC for the technical component, saying your office did the test itself. And then the other office would bill the 92134 with modifier 26, saying they're the ones that actually interpreted the results. Just keep in mind, anytime you bill these modifiers, the patient is most likely going to be responsible for a copay for each visit. The copays are typically per day. So if you separate professional and technical components into separate days using these modifiers, 2 copays will likely be due from the patient. Just make sure you refer to the patient's EOB for the specific responsibilities.
Okay, so we got a couple DMERC billing questions, and I kind of combined them into this slide, and I'll answer both of these. So, and I'm assuming that when this question was submitted, that we're referring to glasses after cataract surgery, since that is the typical billing that I think we do in optometric billing to DMERC. So the first question came in, it says, if a patient has a Medicare Advantage plan, would the claim get sent to their Advantage plan instead of Medicare DME MAC? And the answer to that question is yes. If, just like Melissa had mentioned in an earlier slide, if the patient has a Medicare Advantage plan, that's replacing traditional Medicare, and the DME goes along with traditional Medicare. So if the patient has a Medicare Advantage plan and you are wanting to know if they have a coverage for glasses after cataract surgery, you would need to call the plan and check to see if the plan has a separate benefit for glasses, and specifically saying, does this Advantage plan cover glasses after cataract surgery billed medically? The benefit would be completely separate from any vision service. If there's a vision rider along with the medical, this would be a separate benefit. And when the patient has a Medicare Advantage plan, again, it would completely replace the traditional Medicare. So in the case that the patient doesn't have a separate benefit under the Advantage plan for something like glasses after cataract surgery, then your next option would be it's either patient responsibility, or if there is a vision plan separate from the medical, you would bill the glasses as a standard pair of, glasses underneath the vision plan. Even in that case, you would not bill that directly to DME, because it's going to come back saying this patient has another, another payer, primary payer, or there's something specific that it'll say that the patient has an advantage plan. So the next question that came in is, do you have a step-by-step guide on how to submit post-op glasses claims? So I don't have a specific guide, but I will kind of point out some key pieces of information that are needed in order to bill something like glasses after cataract surgery. First is kind of, coinciding from my last question. If this is being billed to a Medicare Advantage plan, call and ask if their requirements follow Medicare, right? The requirements that DME have for billing a claim may not be the same requirements that are necessarily needed on a claim you're sending to an Advantage plan or a replacement plan. So if you are, the first thing you want to do is make sure that you are a DMERC provider before you can bill to DMERC. You wouldn't send these claims to traditional Medicare. And just because you are enrolled in traditional Medicare, it does not indicate that you're enrolled with DMERC. That's a completely separate credentialing. There is an additional fee. There are revalidations separate that you have to do with DMERC. If the claim, again, is for an Advantage plan, you want to check eligibility before billing. If the Advantage plan does follow the same billing format, this is the format that Medicare or the DME would require. So on the claims, you always want to bill a place of service of 12. You always need a right and left modifier on each line item other than the frame line items. So that's only the frame does not have a right or left. The date of service has to be the dispense date. The diagnosis that's billed on these claims is the presence of an intraocular lens. So it's the Z96.1. Box 17 on the claim would need to have an ordering provider listed. Your charges for your lenses, you have to have a base lens charge, and then you also have, like, if it's a progressive, it needs to be separate. They're on separate line items, and they're split up individually. So that way, when you submit the claims, it'll indicate the coverage on the base lens, and then anything on the progressive, anything that is billed on the frame that is an overage charge, you have to bill with a V2025. The base or the base frame would be a V2020. So there's two separate charges. One is indicating that that's what DME is going to reimburse. The V2025, the additional charge of the frame, that should process as patient responsibility. For your lenses, if your base lens was a bifocal, you would have the V2300 on two separate lines. That's what would be reimbursed. If it's a progressive, then you would have your V2781 on two additional lines, and those would process as your patient responsibility. So if there are any enhancements such as transition, AR, things of that nature, those are non-covered items. So you could go two different routes. There are two different DME contractors that you would bill, and each can be a little bit different on what their requirements are. You have to bill those enhancements on a separate claim if you need it to process. Maybe there's a secondary that you need to get reimbursed by. So those non-covered items can either go on a separate claim directly to your patient, or on a separate claim and bill them separate from the initial claim with your base lens and your progressive and your frame overage and your frame.
Okay, thanks, Casey, for that. Next question, just moving to a little bit of a different area, is about payer portals. We've received a few questions about those, and I'll be answering two here. I hear that having access to payer portals is important. I am new to my role, and the previous person didn't keep good notes of logins. How do I know which payer portals I need to access? I'll go ahead and start with that one. I would recommend starting by looking at what payers your office takes. Immediately for those that have claims that need keyed directly on the portal, for example, IMED or VSP, these portals are a must. Next, I would look at the other payers your office takes and see where their information is being retrieved. Are you getting your EOBs on a clearinghouse through the mail, or you're not certain, where they're coming through? Even if your EOBs are being retrieved through a clearinghouse, having access to the payer portals for the payers most commonly used in the office is a good idea. As having these portals, there's a lot of benefits for having them. Eligibility information, assistance with aging claims, and depending on the site, the possibility of sending secure messages, having secure chats, or uploading direct documents directly to the payer. Some payers use sites such as Availity or One Health Port, on which many different payers are available. So those are also great sites to have depending on your office needs. But I would say having access to more portals is definitely better than having more limited access. So then the other question was, many insurances are now sending paperwork stating we have been paid, but no remit is attached. Logging into each portal is time consuming. Any tips on how to resolve this? So it is true that some insurances are now requiring you to access the portal in order to get remit information. For instance, Change Healthcare, PaySpan, or Availity, to name a few. Insurers are doing this for various reasons. It's more secure to log into a portal to access information. As we all know, things can get lost in the mail or misplaced. You will have it available in the future without needing to contact the payer to fax or resend that EOB if you need it. And it's also more environmentally friendly and cost efficient, does cut down on the amount of paper and postage they're sending. Each payer does have a different policy on how they want their EOBs to be accessed. So it may be possible to have the EOB available through your clearinghouse instead of needing to log into each payer portal to access. This would allow all of your payments to come into the one area instead of needing to log into the different payer portals as you receive the paperwork. Checking with your clearinghouse to see if the various payers are available to be set up with electronic remittance advice through their site may help eliminate some of the logins for EOB retrieval. But as mentioned above, it is really a benefit to have many different portals for a variety of reasons.
So along the same line was a question about United Healthcare portals specifically. And this one can definitely be a little bit confusing. So the question is, I am confused by the United Healthcare portals. Do I need to be signed up for both Optum and the United Healthcare portal? So assuming that the person who asked this question does participate with United Healthcare, the short answer is yes, most likely. So United Healthcare has a main portal that's called the UHC provider portal. And this portal is used for most eligibility and claim status inquiries for most UHC members. Now, some of the UHC affiliates like AARP and UMR, they have their own semi-connected portal. So if you try to look up eligibility or claim status for these members, for example, on the United Healthcare provider portal, you'll actually be directed to a separate website and asked to log in there. Now, they are all connected through your One Healthcare ID, but do require a separate registration initially. They are all advantageous to have, though, if you participate in these different networks, and we do recommend having them all. Now, the Optum portal is similar. It's linked in the same sense that it uses your One Healthcare ID, but you do have to register for it separately from the UHC provider portal as well. So the Optum portal is used primarily to see payment details through Optum Pay. If you get your remits through the clearinghouse, you don't necessarily have to have access to Optum Pay. However, with that being said, it really doesn't hurt to at least have the free version of Optum Pay set up. In my experience, there are occasionally some payments that only come through Optum Pay. So just to be sure you have all needed remits, I would recommend registering for it. if you participate with any UHC plans, including AARP and UMR. So in other words, you do want both the UHC portal for eligibility, benefits, and claim status, and the Optum portal for payment details.
Okay, another question on portal access. Our old office manager was set as admin on most payer portals, but she is no longer an employee. We are having a hard time removing her from our portals. Any advice? So each payer and site should have ways to allow your office to reset the portal. In some instances, this will require the owner doctor call the payer or portal and provide certain information or fill out a form. Sometimes they can also require a notarized letter on office letterhead to get the admin on the account changed. To help in the future to prevent this, we recommend having the owner doctor set as admin, as well as each employee having their own unique login. Well, this can present challenges, especially with more and more sites going to two-factor authentication. It does allow for the best control for the office to know who is accessing what portals, and if an employee leaves, it allows for their access to be turned off without much disruption to the rest of the team. More and more sites are also requiring each individual accessing the site to do so through their own unique login.
And moving on to a few questions regarding timely filing and aging claims. The first question, it's how do I know what timely filing is for a payer? Timely filing guidelines vary by payer. You should be able to find the exact information in the provider manuals for specific insurance, which if you have portal access would be even easier to find. Medicare, Railroad Medicare, along with CHAMP VA, TRICARE, and TRICARE for Life have the largest window of 365 days from the date of service. Most commercial plans vary between 90 to 180 days. You want to make sure you have claims submitted within these timely windows because once received and processed, even if it denies, your timeline is now extended because then it falls under separate time limits for, say, replacement claims, reopenings, or reconsiderations. Now, when it comes to vision insurances, they also have their own particular timelines. These timelines have a little variation to them when it comes to the type of submission being used for the claim. For example, VSP allows 180 days to submit on Eyefinity, but after that, up to 365 days from the date of service on a paper claim, which you would then have to include a letter explaining the delay for the submission. Most other vision insurances will allow up to a certain time frame on their portal, but then the claim must be submitted on paper by mail or fax with a reason for the delay. To the second question asked here, what have you found to be the best rotating schedule of watching and resubmitting claims as they age? A big one would be at the beginning of the month, take a look at your total aging. Take a look at the total number of claims listed, divide that by working days in the month. This will give you a number of claims you should work daily to be able to work all aging for that month. From here, you can dig deeper and have a process for which claims to start with. Start by taking into account the timely filing deadlines for your payers. Work the claims that are just about to hit that payer's filing limit by making sure that they've at least been submitted. You never know. There could have been an issue with your clearinghouse getting the claim to the payer due to technology issues or a rejection. And of course, if it was mailed, it may not have even made it to the payer to begin with. If the claims have been submitted and received, and possibly even processed, start with the oldest claims and work back to the most recent. Another good thing is to work by individual insurance company, because this can help if you're, say, on that payer specific portal or possibly even on a phone call with that payer. You'd be able to work multiple claims in one pass. And in that case, you're able to just tick away at little parts of it throughout the month and be able to touch all your aging that month.
All right, so there was a question that came in on coordination of benefits with medical, vision, and Medicaid. So a patient comes in for a medical eye exam but has Medicaid, which includes both medical and vision coverage, and VSP individual plan, which does not include essential medical eye care benefits. Since Medicaid is always billed last, are we obligated to file vision to VSP? So if the patient has a medical insurance, right, it's not really mentioned here, but I do want to say this would be the primary payer. And then if only well vision is available through VSP, the balance after the primary medical pays can go to Medicaid. It doesn't need to go through VSP first. However, if the patient does not have a medical payer and only VSP and Medicaid are available, thinking maybe that's also possible in this example, and VSP does not allow the medical exam for the patient, you would then file directly with Medicaid. If Medicaid has additional questions, I would recommend submitting the patient's benefit sheet to Medicaid from VSP to show the patient does not have that benefit available. Now, each state and payer are different when it comes to VSP and Medicaid, with some Medicaid plans working through VSP for all benefits. So it is important to know your particular payers and state to know for certain the best way to submit the claims. Now, there are situations in which items would need to go to VSP first prior to being submitted to Medicaid. For instance, even if the patient has used their routine benefit or glasses benefit, it would still need submitted to VSP to get a denial prior to being submitted to Medicaid, as Medicaid is the payer of last resort and needs to see that VSP will not process the claim.
All right, so this is our final pre-submitted question. I know we're almost out of time. We will hang on. We had a few questions come into the question panel, so we will try and get to all of those questions. If you guys don't mind staying a little bit long, we'll get to your questions. So final pre-submitted question is on LASIK. It does read, what CPT should be used for post-op co-management for LASIK if we're not billing to insurance? Now, while there may be some situations where it is deemed medically necessary, LASIK is still largely just an elective procedure and not covered by insurance. So when itemizing it to bill it to patient, most offices use the HCPCS code S0800, which is defined specifically for LASIK. Some also use CPT code 66999 as the procedure code. And this code is defined as unlisted procedure anterior segment of the eye. Just note that this would differ from PRK. The HCPCS code typically used for PRK is S0810. All right, so as I mentioned, that concludes our pre-submitted questions. I'll give you just another couple of moments if you have any additional questions to submit. While I do that, I just want to review briefly a little bit more about RevCycle Partners. So again, we are RevCycle Partners, a revenue cycle management company. We do offer 3 core services, the first of which is billing. We do provide both billing for medical and vision claims. You can choose to sign up for one or both of these, medical or vision, or even just a set of specific payers if you would like. Included in our services for just a percentage of your net receipts from the payers, that means excluding copays, deductibles, et cetera, from the patient, we will scrub and submit your electronic claims, fix any rejections or denials, handle appeals, post payments, work your aging claims, the whole 9 yards. The second service we offer is eligibility and benefits. With this, we will verify both medical and vision benefits for your patients that are scheduled at least 2 days out. We will give you info on their eligibility, copays, coinsurance, deductibles. We'll let you know who's primary, who's secondary. And then the third service is credentialing. We do offer both a project-based service and a maintenance service. The projects are custom scenarios, such as credentialing a new hire for your practice, adding a new payer to your organization, or just simply changing demographics with the payers when someone has a name change, for example. The maintenance service is an ongoing service where we will handle all of your attestations, re-credentialing, and updates with the payers, such as providing them with new copies of your licenses or liability insurance when those renew. If you're interested in learning more about any of our services, please feel free to reach out to us using the contact information on this slide. I'll leave it up while we answer the last few questions that did come in. So the first one we have is, what is the significance or importance of using CPT-2 codes? Any cons of not using them? When billing division plans, they require CPT-2 codes. So what happens if my doctor does not use them? When do you guys want to answer this? Do you want me to take it? No, I will take your silence as me. So CPT-2 codes, really, they were designed for some of the quality reporting that Medicare and CMS, right, is looking for. These vision payers, just recently we've noticed that they are now requiring them. They've kind of, at least IMED has asked for them for a long time. They want you to report the medical diagnoses. If you look at your provider manual, there's a set of medical diagnoses they say you have to report to them. And with those, there are CPT-2 codes that just provide additional information on, the quality of the service that you're providing. And these payers are passing that information along to CMS. So that's really the purpose of them. Now with some of the recent changes, VSP, for example, when you submit a claim that includes diabetes, you have to include the CPT-2 code. It will reject or deny if you miss those. And IMED as well, they're requiring for some of those medical diagnoses that you select a CPT-2 code before you advance. What'll happen if your doctor does not use them? I would encourage you just to review the provider contracts that you have, the provider manuals. They do say that you're contracted to provide that information to these payers now. So I think you would just want to review that and be careful and make sure you're not found in violation of your contract if you don't report those. Now, is there a code for children's near vision lenses? The example that was given is billing for Eisen.
I'm not sure I've heard of that, Melissa, myself.
I know that Eisen, I've recently started seeing a little bit more submissions for that. I think it's still largely listed as an unspecified HCPCS code. At least that's the way I've seen it in most of our practices that are billing that. I don't know that there is a specific HCPCS code for it yet. So I think that would be a great circumstance where if you're not 100% sure, if the patient seems to have a benefit for it, I would just contact the payer and speak with one of the reps. VSP, for example, it's got some really great reps who'll kind of help you with some of that. All right, are we able to choose not to COB medical division plans, even if we are a participating provider for both?
I can help with that one. So even if you are, a provider for both, you do not have to COB. I would encourage you, if it's something that your office is thinking about, to look at the provider manuals and see what their processes are and what their requirements are. Each payer does have different things they will COB with. For instance, VSP will do exams and refractions, and if the benefit's available, some medical items as well, whereas IMED limits it to refraction only and very, very specific plans. So if your office does decide to do it, also making sure that the patient is aware that you're doing it and that they want you to do that for them, because it does use up their well vision benefit. So you don't have to COB. If you do COB, you may not do it for all of your patients. There may be patients who aren't interested in having that service done for them. So I guess short answer is no, you do not have to.
Good. And then going back to the visual field 92083, do I bill 2 fees with 1 unit for left and right? I think they're talking specifically about that modifier 50 that you were mentioning, Casey.
So possibly, but I was looking at this one because a visual field, it's considered a diagnostic test. It already is including, it's a one fee. So when you're doing a visual field and you're billing it, you would not append the right or left. It's already a bilateral CPT code. So it's including a price, assuming that you will perform the test on both right and left eye. There's going to be very rare instances, other than maybe if someone is completely blind or does, doesn't maybe have vision in an eye. In that case, you could report modifier 52 reducing a service, but any other time you're going to perform that service and you're going to get paid as if you've performed it on both the right and left. It's only unilateral codes that you would report on, 2 separate, individually right and left, like epilation, which we talked about earlier. I answered a question too on here, Melissa, and I didn't want it to get sorted. It's under the answered.
Okay.
section. So do you want me to do that one?
Sure, go for it. Just
Kind
so
of
everybody
submitted it
can
back
benefit from
already.
it. Yeah.
Okay.
And that's our
so
last one. So.
there was a question that came in. It said, can you bill a special test, OCT, photos to insurance when you order the test to rule out or make sure the eye is healthy and it does indeed come back healthy? So I'm assuming that in that case, it would be considered not medically necessary. So that would be in situation where an ABN would be really important, because if doctor's performing the test because, there's an indication or an importance of the test that needs to be determined in the medical records and very clearly notated why the medical necessity of billing it was needed. Along with that, your patient needs to be aware that that may come back as non-covered. So you would want to have an ABN on file, or the payer may have a specific form that you have to fill out for not being medically necessary. You have to make sure your patient is well aware of the price that they're going to be charged, that it's specific to the date of service, and that they are informed of that prior to submission. And this would be a good indication of when that G modifier, if the payer accepts that, it might be a good use of one of the G modifiers, indicating that, yes, I know this may not be covered, but I do have an ABN on file. You could submit with a GA modifier. Just make sure your records are clear.
Excellent. Very good. Thank you. All right. So I do think those were all of the questions that did come in. If you have any additional questions, feel free to reach out to us. You can, again, use the information on the contact us screen here. And if you email Sarah or Paul, they'll route those questions accordingly. You can also reach out to us through the information in the webinar invite. So I appreciate all of your time today. Thank you all for joining us. We will have a copy of the PowerPoint slide we can send out if you're interested in it. And of course, the session was recorded. So if you would like a copy of that recording, feel free to ask for it. Thank you so much. I hope you all have a wonderful rest of your day and a wonderful rest of your week.
Thanks, everyone.